Sir, my patient is 57-year-old male, farmer by occupation, a resident of Uttarakhand. He presented to us with chief complaints of yellowish discoloration of eyes and urine since 2 months, with generalized itching since 2 months. Patient was apparently well 2 months back when he first noticed yellowish discoloration of his eyes along with patches of high-colored urine. This yellowish discoloration progressively deepened over time. He also developed itching around the same time, which was initially mild intensity and gradually worsened. And currently, he's having generalized itching all over the body throughout the day, and it is disturbing his sleep as well. He also noticed patches of clay-colored stool since last 1.5 months. And he also complained of loss of appetite and loss of weight, though this loss of weight was undocumented and patient told it was apparent with loosening of his clothes. There is no history of abdominal pain associated, distension, postprandial fullness, nausea, vomiting, hematemesis or melena. No history of fever with chills or rigor or intermittent episodes of, or there was no history of intermittent relief of symptoms. There is no history of previous episodes of biliary repeated episodes of biliary colic or abdominal pain. It was not preceded by any prodromal symptom. There is no history of alternative medicine intake. Patient did not complain of generalized weakness, syncope or postural dizziness. There is no history of previous blood transfusion. There is no history of decrease in urine output or altered sensorium. No history of shortness of breath, cough, hemoptysis, bony or back pain. There is no history of recent onset of diabetes. In the past history, patient did not have any comorbidities and there is no history of prolonged medication, no history of any surgery in the past, and there is no history of similar illness in the past as well. In family history, there is no similar illness in the family, no history of similar illness in the family, and also there is no history of any malignancy in the family. Personally, there is no history of addictions. Appetite is reduced, and his sleep is disturbed since last 1.5 to 2 months. His blood and bowel habits are normal. He follows mixed diet. To summarize, my patient is 57-year-old male without any comorbidities or addiction, presented with 2 months history of painless progressive jaundice associated with cholestatic features, with loss of appetite and loss of weight, without any history suggestive of cholangitis. So, likely the case. So in impression, patient is of obstructive jaundice of likely malignant etiology, sir.
Then when you take a history of 2 months and first jaundice, what do you think? What are possible diagnosis in your mind when you have a history of 2 months?
Sir, 2 months history is a bit short history, and there is progressive worsening of jaundice as well. So, considering the age and the short duration of history, I thought in terms of malignant etiology, though still benign possibilities can be there.
Benign possibility can be there. Which benign possible diagnosis can you can think in your mind?
Sir, it would be rare possibilities only. Otherwise, painless progressive jaundice won't be there in a routine benign hepatobiliary pathologies. But patient can be having IgG4 cholangiopathy or primary sclerosing cholangitis that can give such picture. But these are rare possibilities, sir. Or rarely choledochal cyst with the cystolithiasis can also give this presentation, sir. But these
So
are
as per your presenting complaints, we'll never think of this IgG cholangiopathy in other possible things. Okay, never says this PSC in cholangiopathy.
okay,
On the basis of your history, just having history of 2 months of jaundice itching, then we can think of first any stone disease. Why we are not having any suspicion of stone disease? Why?
Sir, because patient did not have any history of previous episodes of biliary colic. Also, it is clear-cut painless progressive jaundice, sir.
Okay,
So,
why not having choledocholitis? What are the symptoms of choledocholitis?
sir, choledocholitis can present, but it is rare to have choledocholitis without pain, sir.
It's
Patient
not always there's not always some dictum. Patient can have choledocholitis also, but we can't rule out on the basis of history. Because you have when you think of benign etiology, so the first thing jaundice with itching, in our mind, we should come the benign in the for the benign disease. It should be a stone disease.
Okay.
Whatever it is, it can be a coldocholithiasis, or it can be a cholelithiasis with Meniere's syndrome. The possibility of Meniere's also. No doubt, there should be a history of pain abdomen, but this pain is not always related there. Other than pain, what should be the feature that benign pathology should have? Other than pain, if there is no history of pain, other symptoms, what you can think whenever the patient having this Crohn's disease, and we can think of any
Stone
benign
disease,
pathology.
Stone disease patients can have intermittent relief of symptoms, sir. Uh, they can have intermittent jaundice. Patient uh, can have features of cholangitis as well, sir. But these features of cholangitis will be there in can be there in malignant etiologies as well. Though fever, the chances of cholangitis are more with the stone disease as compared to malignant etiologies, sir.
So the other symptom is, we can, in the form of symptoms, we can say fever. One is the pain, which is the symptom, and another symptom is a fever. Patient may have intermittent pain with fever. But in your clinical practice, have you seen the patients? Haven't you seen any patients of Crohn's disease without fever, without pain? It means possibility of the patient having symptoms of pain and without this fever can have possibility. But in the form of benign, another diagnosis is a cold cyst
Yes.
or cystolithiasis. Cold cyst is cystolithiasis. Okay, this benign pathology can be there. Most of the patient when this patient have a this 2 months duration with the itching, we always think of malignant pathology considering patient's age. But in the benign pathology, we should think of about this pathology. In your I think just wait.
Myself, Dr. Neeraj from AIIMS Rishikesh. I'll be presenting today's case, sir.
Hi,
Sir,
hi, yes.
sir, my patient is 57-year-old male, farmer by occupation, resident of Uttarakhand. He presented to us with chief complaints of yellowish discoloration of eyes and urine since 2 months, with generalized itching since 2 months. Patient was apparently well 2 months back when he noticed yellowish discoloration of his eyes along with passage of high colored urine. This yellowish discoloration progressively deepened over time. He also developed itching around the same time, which was initially mild intensity but gradually worsened. And currently, he's having generalized itching all over the body throughout the day, and it is disturbing his sleep now. He also noticed a passage of clay colored stool since 1.5 months. And he also gave history of loss of appetite and loss of weight. Though this loss of weight was undocumented, and a patient told it was apparent because of the loosening of his clothes. In negative history, there is no history of abdominal pain, abdominal distension, postprandial fullness, nausea, vomiting, hematemesis, or melena. There is no history of fever with chills or rigor. There is no history of intermittent relief of symptoms. No history of previous episodes of biliary colic abdominal pain. It was not preceded by any prodromal symptom. There is no history of alternate medicine intake. Patient did not complain of any generalized weakness, syncope, or postural dizziness. There is no history of blood transfusion or decrease in urine output or altered sensorium. No history of shortness of breath, cough, hemoptysis, back or bony pain. There is no history of recent onset of diabetes. In the past history, patient did not have any comorbidities, and there is no history of any prolonged medication. Patient did not undergo any surgery in the past, and there is no history of similar illness in the past. In family history, there is no history of similar illness in the family, and no history of any malignancy in the family. Personal history, there is a patient did not have any addiction, and his appetite is reduced. Sleep is disturbed since last 1.5 to 2 months. His bladder and bowel habits are normal, and he follows mixed diet. To summarize, my patient is 57-year-old male without any comorbidities or addiction, presented with 2 months history of painless progressive jaundice associated with cholestatic features, and there is loss of weight along with loss of weight and appetite without any history suggestive of cholangitis. So, to concluding, my patient is a case of obstructive jaundice, likely of malignant etiologies.
Anand, would you like to start or I would start?
Sir, I was discussing on the second slide. Neeraj, come on second slide.
Okay, quickly going through the slides again, back to your symptoms and history of present illness. So what do you think is happening in this patient?
Sir, patient is having obstructive jaundice. Sir, this patient is all days patient with short duration of history of obstructive jaundice without a feature suggestive of
So
cholangitis.
you think the patient is having obstructive jaundice.
Yes, sir.
So why the patient had jaundice? Why he developed jaundice?
Because of the obstruction in the biliary tree, patient developed jaundice, sir.
Why jaundice? Why his eyes and ear they become yellow? Obstruction, fine. Obstruction is correct. You're saying I accept. But why develop jaundice?
Because of the excess bilirubin in the bloodstream, sir.
Why? How the excess bilirubin comes to the bloodstream?
Sir,
Those-
because of the obstruction, sir, there is no enterohepatic circulation, sir. So direct bilirubin, which is being soluble, it is spilling over, and that is going into the circulation, sir.
Spilling over to where? Where exactly it spills over? And
Sir, at the
what
level of
is that
sinusoid,
spill?
sir.
Yes.
At the level of sinusoid, sir.
Why it spills over? Through what? It
Sir,
is in the bile. Then how it comes to the circulation?
because of the pressure difference. Normal biliary pressure is around 10 mm of mercury, sir. In the biliary obstruction, it raises up to 20 to 30 mm of Hg. Because of that, pressure difference develops, and at the sinusoidal level, it spills over to the portal circulation, sir.
Why it is a maximum affecting the eye? Because there are elastic tissue in the eye which have avidity or affinity for the bilirubin and the bile cells. So there is coloration, discoloration of the eyes, and also the itching is also can be troublesome to the eyes in these patients. Now, why the patient is having itching?
Sir, itching is because of the likely because of bile salt deposition in the skin. Another reason is because of release of endorphins, sir.
Bilirubin is not causing itching. Why bile salts are causing itching?
Sir, bile salt deposition causes irritation of nerve endings, sir, in the dermis, sir.
Why not bilirubin? See, in other words, I think you have
Sir,
crossed
bilirubin
that
is
15-20 minutes. So you must know the pathophysiology of obstructive jaundice. That is my point. So there are theories. It's not absolutely sure why it occurs. There are 5-6 ways in which it can affect. So what are the prurito gens? Then only you can say how to treat this pruritus in these patients. To know how the pruritus is being is taken care of in obstructive jaundice patient.
Sir, we start with medical management of ursodeoxycholic acid, and along with that, cholestyramine.
How ursodeoxycholic acid will cause relief in pruritus?
Sir, it reduces the production of bile acids, sir.
So what will happen?
Sir, it will decrease the further production, so that will improve the patient's symptoms, sir.
No.
That is cholestyramines, sir. These are bile acid binding reagents, sir.
You must know what are the phase 1 drugs, what are the phase 2 drugs, and if it is not working, what is the phase 3 and even phase 4 drugs.
The phase 1 drug is cholestyramine assay, sir. Phase 2, we give rifaximin.
The
Phase
role
3, we give
role of UDCA has not yet even proved in these cases. You think that it is working, but actual mode of action, how it actually does, it is not yet established. Then second line is cholestyramine.
cholestyramine, sir.
Third line is
Sir, rifampicin we use.
rifampicin you can use, and then fourth is antihistaminics.
Naltrexone we use, and sertraline we can use, sir.
That you can give from inside. And what do you do to the skin? He is having severe itching, which would lead to eruptions, infections.
Lactocalamine lotion or emollients we use, sir. so that patient skin dryness could be prevented, sir?
No, actually, if you read, the lactocalamine causes more of dryness to these people. It's a very temporary moisturizing, and then eventually it causes dryness and it causes problem. More important than that is you have to hydrate the patient, number one, and number two, because bile salts, all these are water soluble. Number two is um, cool. I think they have to apply. They keep their body cool.
Okay, sir.
These are the two most important things that you have to say. Why it occurs at night more? Why it disturbs their sleep? I'm just enumerating the questions regarding this, which you may get in the examination, and you will spent about some time on this. So, what are the causes of jaundice with pruritus? You must also know the grades of pruritus, isn't it? Just I'm informing you should know the grades of there are 4 grades which you know. According to that, you have to decide your management. So I was asking what are the causes?
The causes of jaundice with pruritus are obstructive causes of jaundice, sir. That can be malignant as well as benign, sir. So in benign, most common would be choledocholithiasis, sir, and other causes can
So
be because
is it always obstructive jaundice it has to be, or if it is obstructive jaundice, where the obstruction has to be? Hepatocellular cannot cause itching.
so usually hepatocellular jaundice won't cause itching, sir. It is the intrahepatic or extrahepatic cholestasis
What
that
is
causes.
that usual? We are now at the stage of history and symptoms and signs. So you have to have a wider variety of differential diagnosis. So as the process goes in, as we move further and proceed, then we have to exclude one by one and reach for about 2 or 3 diagnoses finally. So one is a obstructive jaundice. Second is it could be
It could be
hepatocellular.
intrahepatic cholestasis can cause pruritus and jaundice, sir.
So basically, you have to say according to the pathophysiology type. It could be extrahepatic biliary duct obstruction. It could be intrahepatic biliary duct obstruction, which could be intrahepatic, could be at the cellular level, or intrahepatic biliary canaliculi.
The cellular level
So,
or at the
so
cell.
it could be outside extrahepatic. We will come to that, which is more common. And hepatocellular, all hepatitis can cause, all types of hepatitis can cause itching. Chronic active hepatitis can cause chronic itching, canalicular varieties. And there are certain genetic diseases which can cause pruritus and jaundice. What are they? So what is
Dupin Jones, sir, or
what is familial intrahepatic cholestasis?
Sorry, sir, I need to read about
And you should know those causes. Straightway, you will say obstructive. There are hematological causes also, like sickle cell anemia, protoporphyria, sepsis, and cystic fibrosis, which is not common in this patient, of course. And there are conditions in which ducts vanish, ductopenia. So, what are the conditions of ductopenia, which can cause jaundice as well as itching? Commonest is primary sclerosing cholangitis, and another one is primary biliary cholangitis. Otherwise, earlier on, it was known as primary biliary cirrhosis. Or it's known as primary biliary cholangitis. So, what is the difference between primary sclerosing cholangitis and primary biliary cholangitis or primary biliary cirrhosis?
The primary sclerosing cholangitis is inflammatory disorder of the intrahepatic biliary ductal system.
So, what happens?
So
Can it be a differential diagnosis in this patient?
yes, sir, it can be differential diagnosis.
You have to keep it in history, and when you are discussing history and symptoms and signs. So it is autoimmune disorder. What happens in this? In PSC?
In PSC, there is
extrahepatic ducts can be involved or cannot be involved.
Can be involved, sir. Intra as well as extrahepatic can be involved, sir.
Yes. So the patient will have almost similar symptoms, but a case of obstructive jaundice occurs. So in the history of present illness. You said jaundice, itching, clay-colored stool, appetite, and weight.
Yes.
And in negative history, you said waxing, waning, fever, pain, bleeding. Okay. So why bleeding would occur?
Sir, in case of ampullary malignancy or ampullary pathology, sir, the patient can have a bleeding, sir.
Why gastric?
Because of the tumor sloughing itself, it can cause bleeding, sir.
So you have to straightway you have decided it is malignancy.
No, sir, that can cause sir, that can cause bleeding, sir. Other than that, patient can have medical jaundice. Because of that, patient can have varices that can bleed, sir.
So I would accept that in periampullary pathology that could be. And what about the stone disease?
Stone disease, sir, if patient is developing Meniere's type picture, that can also cause bleeding, sir.
Stone can erode as a remote possibility. It can cause bleeding, though it's not the commonly the situation. You asked about altered bowel habit. Why?
Sir, altered bowel habit can be there in case patient is having inflammatory bowel disease, and that will suggest us towards primary sclerosing cholangitis, sir.
So that's why I wanted to say the differential diagnosis should have included. So the basic difference between primary sclerosing cholangitis and primary biliary cholangitis or primary biliary cirrhosis is primary sclerosing cholangitis is a extrahepatic involvement. Primary biliary cirrhosis is an intrahepatic involvement. Biliary cirrhosis commonly involves the females, and primary sclerosing cholangitis commonly involves the males. And there is IBD associated with PSC. IBD is not associated with PBC or biliary cholangitis. Primary biliary cholangitis usually doesn't proceed to form cancer, whereas primary sclerosing cholangitis can proceed on to develop cancer. Okay, and uh, primary biliary cholangitis or cirrhosis, UDCA or ursodeoxycholic acid can be effective. Here it won't be effective. So these are the basic differences you should know between these two. You asked about cough and expectoration and hemoptysis. Why?
Sir, if we are considering towards malignant etiology, so patient can have metastatic disease in the form of pleural effusion that will cause cough, and hemoptysis can also because of metastatic lung deposits, sir.
That's why I asked about back pain and bony pain.
Yes, sir. I asked about back pain, bony pain because of to rule out metastatic disease only, sir.
Why dizziness?
Sir, dizziness patient can have had episodes of bleeding that could cause dizziness, or patient could have had metastatic disease in the form of brain mets that could also cause postural dizziness or seizure episodes, sir.
In the family history, what history was important for this person? Which
Sir,
family history is more important that you should have asked?
Sir, had the patient's family had any pancreatic cancer, so that could suggest towards hereditary pancreatic cancer syndrome, sir. So it could be seen in hereditary pancreatic cancer, PRSS1 gene mutation, or familial adenomatous polyposis, or hereditary non-polyposis coli, sir.
Yes. Those history you should take. They could be associated with precipitation of some biliary cancer, biliary tract cancer later on. And in personal history, you asked for mixed diet. Why mixed diet? How it is important?
Sir, red meat consumption. Sorry, sir, I'm not sure about the.
No, last time, I think last class when we are discussing, I told you there is a difference in presentation of MBBS, MS history, and MCH level history. Here, we are a little bit more advanced. So rather than presenting the raw presentation of what patient is saying and what you are getting, your presentation has to indicate towards your diagnosis. So you have to be very, very selective in your presentation. So whatever is connected to your diagnosis, that means we will know that you are trying to arrive at a decision. You can ask lots of personal histories, but not necessary you chalk them down here. For that should have a logical conclusion towards the diagnosis. Okay. So Anand, did you discuss about the examination?
Yes, sir. We can continue. Sir.
No, you discussed about examination.
No, sir. No, sir. Just we were on the history only.
Ha,
Basically, we
so
were discussing these patients may have a benign etiology also. Maybe possibility of the choledocholithiasis and Miriges syndrome. But there is no history of pain abdomen, the fever. Their possibility were less likely, but can have the symptoms. Then they can have like results.
now tell me in order of occurrence, the chances of having the particular disease in this patient. Tell me the differential diagnosis.
Um,
So
sir,
basically, it's a 70-year male,
57.
7-year-old
57-year male, jaundice with pruritus, with this type of history. What are the differential diagnoses? Just
considering
enumerate.
considering the old
So
age patient with progressive
we
history,
have first the malignant. We have first the malignant etiology or the benign etiology. You said it will be malignant etiology
first
first, and
I'm
then benign
considering
etiology.
malignant etiology, sir.
So, what are the malignant etiologies?
Sir, in malignant etiologies, I'm considering periampullary carcinoma, carcinoma head of pancreas, hyalocholangiocarcinoma, and carcinoma gallbladder. I kept this periampullary carcinoma as my first differential because of the incidence itself, sir. And second in incidence is carcinoma head of pancreas, sir. And in Indian scenario, sir. Though incidence-wise, carcinoma gallbladder is much more common than hyalocholangiocarcinoma, but mostly more than 75% of the patients with carcinoma gallbladder will have history of recurrent episodes of biliary colic, and history of pain will be associated in such patients. So I have kept carcinoma gallbladder as down as compared to hyalocholangiocarcinoma because of that, sir.
What type of, okay, say, let me enumerate like this. Sorry. So, I would keep my diagnosis like this. So, if you say periampullary carcinoma, and then second you want to put pancreatic head malignancy. Third is there are four biliary tract malignancies which you should be able to always differentiate when you are presenting a obstructive jaundice. One is a cancer gallbladder, second is a periampullary carcinoma, third is a head of the pancreas malignancy, fourth is a hilar cholangio. These four. Along with that, always you should keep an option of secondaries. Secondaries involving the lymph nodes, then compressing the duct, and you should be able to keep these five in malignancies at least. What is the difference? You should be able to differentiate on clinical scenario. See, gallbladder cancer is not like that. You are saying there always it has to be pain and jaundice. More often than not, the gallbladder cancer is a painless jaundice. Pain and in periampullary, it could be intermittent jaundice.
Periampullary would present with a picture of waxing waning jaundice.
Jaundice painless. In
With
pancreatic head tumor, it would be more or less a continuous type of jaundice. In hilar cholangio, it will be
progressive jaundice, sir.
painless.
Painless progressive
It will
jaundice.
be again painless progressive jaundice. Now, in carcinoma gallbladder, you have to be very specific that it has to be the gallbladder neck malignancy. Gallbladder neck malignancy, periampullary, HOP, hyalocholangio. The pain in gallbladder cancer neck will be dull, diffuse.
Diffuse pain.
This is mostly when the liver is involved or stone is there. Okay, until unless that occurs, you may not get pain in these patients. And other causes of carcinoma, other causes of pain in carcinoma gallbladder are presence of stones inside or complications like empyema. Okay, or blockade of the cystic duct, tense gallbladder, that they could be painful. And in hilar cholangio, particularly, you should be very careful in differentiating CAGB neck and hilar cholangio, which mimic so much each other. It's very difficult to differentiate. This is where the examinee actually gets stuck. So you have to have your tab in a tabular form the differentiation between these four, particularly these two. So
In Hyler, it, patient may give history of pruritus preceding the jaundice, though it is not always present, sir.
when pruritus is the initial presentation in obstructive jaundice,
Sir, in
the
PSC, in
the
primary sclerosing cholangitis patient can have pruritus before jaundice, or patient in hilar cholangiocarcinoma patient
no,
can have pruritus.
the incidence is 80 to 100% of the patient in cholestatic jaundice. You have pruritus, and about one-fourth of them, the primary symptom is pruritus. One-fourth. Okay, here you had jaundice, and then you have pruritus in this patient. Okay, now the differentiation we're discussing, gastric outlet obstruction, common in which of the four?
Pancreatic head cancer and gallbladder cancer patients can have this gastric outlet obstruction, sir. Though periampullary involving duodenum, sir, that can also cause gastric outlet obstruction, sir.
In cancer gallbladder, you can have gastric outlet obstruction. In periampullary, it is rare. Head of the pancreas, when it becomes bigger, you will get in late stage. And in hilar cholangio, it is usually not there. So then, other than that, we have benign conditions which also we enumerated, including what Dr. Anand said. The stone disease you must keep higher up in these patients, and then benign tumors also, and biliary strictures, oriental cholangitis, all this, which would be, of course, more of pain and more of cholangitis than painless progressive jaundice. So, on the examination, what are the positive findings you got for your diagnosis?
Sir, in positive findings, patient is thin build, sir. Patient has echo performance status of 1 with the BMI of 20.
Positive findings. See, in your examination, I'm having your presentation in front of me. In your examination, you said I'm examining this patient in a well-lit room, sitting posture. Why sitting posture?
Sir, supine and sitting posture while examination of respiratory system, sir.
So, are you examining the respiratory system of the patient?
No, sir. That is for the complete examination.
And in sitting posture, you are examining the patient, and you are writing patient is not unconscious. What does that mean? How a unconscious patient will sit up? So those are MBBS level things. Unnecessary. This makes your presentation value is little bit less. It gets diluted by all these things. So where do you exactly examine the patient of jaundice?
Sir, in the sunlight, sir.
Sunlight. So that is more important than well-lit room inside. So you said the patient has a ECOG status. ECOG 1. ECOG 1.
The patient is able to do his routine duties.
Why did you say that? ECOG 1.
Because I was considering malignant etiologies more as compared to benign etiology, so that's why I told in terms of ECOG, sir.
What is the other common one? If you
So
really
WHO performance status. Process.
Is it that we count more or Karnofsky?
Karnofsky also we use, sir.
So ECOG 1 is equivalent to which Karnofsky?
Sir, it is 80 to 90, sir.
It's about 70 to 80%. And why should you mention performance status? How it is important?
Sir, because in these patients we might be planning for operative intervention, sir. So ECOG performance status is important for that point. Will the patient be able to tolerate the surgical stress or not, sir?
What is tolerate? See, the answer is you should say that the studies have shown that the ECOG status, the performance status, has a direct correlation with the operative outcome in these patients, and particularly when we are speaking of malignant obstructive jaundice patients. It is for other cancer patients also, but this is what is the answer. That's why I need to know what is the performance status of the patient to know the prognosis or how much this patient can withstand the surgery and what should be his outcome. So I try to, and then it would be, the question would be, do you think if I improve his performance status, you do better after the surgery? Should I go for that or not?
Yes, sir. Improvement in performance status will improve the post-operative morbidity and mortality rates, sir.
So you try to see for cyanosis and clubbing. Though I can tell you that cyanosis and clubbing could be one of the late manifestations of this in these patients, particularly if the liver is involved. So if you are writing something, you must be able to stand the questions. And
Clubbing could be because of
why well hydrated?
sir, because jaundice patients can be having cholangitis along with it, or patients are tend to be dehydrated, sir. So that's
Why
why I.
a cholangitis patient will become dehydrated? This is how the examiners will go on asking you. This I'm not doing a leg pulling, but I'm telling what happens is in the examination, if you are asked these type of questions, then you tend to lose your composure. Think what is happening. The examiner is asking all these questions. I'm just stopping at that point. So they just disturb your rhythm. Like for example, you wrote pulse rate 84 per minute. What happens in jaundice?
In jaundice patients pulse rate decreases, sir.
So why here the pulse rate is normal? You thought that. Now you paused a little bit, thinking what is happening. So that's why my point is, whatever you are writing, you have to have an answer. Then you might be saying, not in all patients, the jaundice causing bradycardia is because of the sinus SA node
I cannot support.
involvement, but that is not a fact actually. It has never been proved, and not necessary that all of them would have. There are trials which have shown that they have taken a good number of study jaundice patients, studied, and it was never found in those studies that actually this is the pathway which is causing, or all of them are having bradycardia. It's not a fact. So at this stage, you should be able to discuss at this level. Um, then in abdomen, you said on inspection, hernial orifice is intact. What does that mean? How could you see the hernial orifices which were intact? So similar things, we can go on discussing all these things at length, but these things are to be corrected. Okay, and in PR, per rectal examination, what do you expect? What do you actually look for in these patients?
Sir, I was looking for any nodularity palpable in the form of metastatic deposit, sir. I was looking for Bloomer cells, sir.
So you have to write exactly that. There is no Bloomer self. Or Bloomer self is negative, rather than writing all these things, nodularity, fistula, sinus. In negative abdominal examination, you should have mentioned whether there is right upper quadrant tenderness is there or not there. That would indicate
That would indicate either cholangitis or patient
whether there's the liver tenderness is there or not.
tenderness is there.
And you should have mentioned there was no palpable gallbladder, no
Yes, sir.
palpable spleen. Rather than these should have been more specified rather than organomegaly. Okay. Even rectal varices, if you would have mentioned, I would have been more happy rather than writing sinuses and fistulas. Okay. So now, what are the differential diagnosis after this examination?
Sir, my differentials after examination are,
Remained the same or it changed?
sir, considering gallbladder is not palpable, though it is not seen in all the periampullary carcinomas. I'm keeping carcinoma head of pancreas and hilar cholangio before periampullary and gallbladder cancer, sir. Sir, because patient no, gallbladder is not palpable, sir. So in around 60 to 70% of the patients with periampullary cancer, gallbladder would be palpable, sir.
So you would take 60-70% or 30%? I would little bit differ with you. Say you should take what is common. If you say common things, you'll be commonly correct. So if I commonly think gallbladder is not palpable, so I will keep all these things down. Then of course I will ask, even if it is there, why they are not palpable. Then I would answer. But in your case, I would put carcinoma, gallbladder first, and then a hilar cholangium carcinoma, a periampullary carcinoma, because it is a painless progressive jaundice, and lastly I would put carcinoma head of the pancreas. Okay, this is my opinion, and you can argue about it. It's not that what I am saying is 100% correct. Anything out of this could happen, but you should be able to say on the basis of common findings. So these are the four things that we are narrowing on or zeroing on our diagnosis. Then what should you do, Anand?
Yes, sir.
Investigation, please start. Short.
Sir, I would start with the blood investigation in the form of complete blood count with the liver function test of the patient and renal function test.
Neeraj always comes. Then I would like to review all the older reports. Okay, and then report, and you will show the report for the verify if he have.
I have these reports, sir, with me. His complete blood count is normal, sir. Hemoglobin of 11.5 gram, and TLC counts are not raised, and platelet counts are normal, sir. Then in liver function tests, sir, patient is having direct hyperbilirubinemia along with the raised ALP and GGT. So patient is having obstructive jaundice, sir, and patient is also having a transaminitis. So patient, this transaminitis could be because of cholangitis per se, or it can also be because of cholestasis-induced necrosis. So it could be both the things. And patient's albumin is 3.7. It is more than normal. So it suggests nutritional status as well as synthetic function of the liver, sir. So patient is preserved in terms of nutrition, and synthetic function is also preserved, sir. Also, PTINR is normal. So this again shows synthetic function of the liver. So synthetic function of the liver is preserved, sir. Renal function test.
Neeraj, here you should be very well versed about the what happened about what happens to these enzymes in different types of obstructive jaundice patients. So you may be asked about OT, what is OT, what is PT, when does it increase, and why you are doing alkaline phosphatase and GGT both. Why did you do both in this patient?
Sir, to confirm the obstructivity also itself, sir.
Why both? Which is more from where the alkaline phosphatase comes and from where the GGT comes?
Sir, alkaline phosphatase comes from biliary epithelium, sir. So
And GGT? And
sorry, sir.
from where the GGT comes? What are the? It also comes from there, but it's more specific. It doesn't
More
come
specific.
from anywhere else. And alkaline phosphatase is a screening investigations for them. It is even cheaper. It's available everywhere. GGT is not there. If I am really suspecting obstructive jaundice, I would go for rather gamma GT. And alkaline phosphatase is easier to follow up in these patients. Gamma GT is not available everywhere and it's also costly, but it is absolutely specific. So if you're having confusion regarding what could the cause of obstructive jaundice or whether this isolated alkaline phosphatase raise, suppose, then that could be because of other causes, the bony causes and all those. So you want to be very specific, you do gamma GT. Can you answer how do you differentiate between a stricture versus a stone by the liver enzymes? So in case of stricture, there is increase in alkaline phosphatase and gamma GT. Okay. In case of stone, along with that or even without that, the first thing to increase is the AST. AST is
SGOT, sir.
SGOT. So you should be able to say that. Okay. And what is the normal gamma GT? You should be able to know the normal values. You have not written the normal values. They are mentioned.
Reference range in our lab is 35, sir.
So you should keep the lab value. It is not the level which is important. It is the time, how many times it is raised, that is important. What is significant?
Sir, more than 1.5 times of upper limit of normal reference range of that particular lab is significant, sir.
Better to say it at 2 times. Okay. So people, I agree, but better 2 times. It will be even better if you say 3 times, because there is lab to lab variation, and again variation in patients. 1.5 you try to suspect, and 2 or 3 times is definitely some increase. Okay. And why PT-INR is, you have done PT-INR?
Sir, PTNR I have done to look for synthetic function of the liver, one thing, and the patient may be having patient is having obstructive jaundice that could cause deficiency of vitamin K. So in that scenario, INR would be raised, sir.
Why APTT? Why not APTT? Which detects the intrinsic pathway in obstructive jaundice, which is important?
The intrinsic pathway is important in obstructive jaundice. It is detected by.
Yes. So what are the intrinsic pathways? What are the factors comes under intrinsic pathway? 8, 9, 10, 12.
Yes, sir.
Okay? 8, 9, 10, 12. So both you have to note, not that you have to know only the PT. Okay. And in renal function test, you have written TLC. What is that TLC?
Sorry, sir. It was by mistake, sir. I have corrected that.
Okay. So that one. So why it is important?
Sir, patient can be having a renal dysfunction, sir, because of the cholangitis or obstructive jaundice per se, sir. So that will increase the blood urea and serum creatinine, sir.
And the hydration status of the patient. Okay. Next. So my question is, if a patient comes to you, you are suspecting malignant obstructive jaundice. You are suspecting. It's not that the patient has come with jaundice and you don't know what is the cause of the jaundice. Versus a patient where you were strongly suspecting obstructive jaundice. You would go for all these hemoglobin, DLC, TLC, platelet, all these things are more important, or you should go for a screening diagnostic test.
Sir, I would rather do both the things, sir, for blood workup to rule out cholangitis and to ensure the diagnosis of obstructive jaundice in a liver function test. Also, I would do ultrasound abdomen to look for etiology of the jaundice, sir. Etiology and
So how hemogram is important in this patient when you can see that there is no anemia?
Hemogram is important in terms of TLC count also, apart from anemia, sir. If the TLC counts are raised and patient is having picture of obstructive jaundice, so patient may be in cholangitis, sir. And accordingly, if the platelet count is also less than 1 lakh, so it grades the severity of cholangitis as well, sir. If counts are more than 12,000 or less than 4,000, then it comes towards.
Do we treat cholangitis on the basis of TLC?
No, sir.
So see, I would be happy in this patient where at this stage of your career, when at this level when you are presenting, I would be happy if you go for a you if you mention about a screening investigation in the patient when particularly I know clinically these things are happening. There is no evidence of cholangitis. There is no anemia. And he had jaundice, of course. If you do all these investigations again, by the time you go, you take him for management, all this, you may have to repeat all these routine investigations again. So it's fine if you answer that I will go side by side these investigations as well as the diagnostic investigations. But if I have to ask you which one you would go first, you have to have a choice. Then obviously the
I have
screen,
to go for ultrasound abdomen.
they can get a back seat, but I will go for it because on the basis of this, I'm not going to treat the patient now. So the screening thing. So in screening, you will have ultrasound. So what is the ultrasound finding? Do you go for tumor marker at this stage? Immediately within all cases, routine investigation, tumor marker?
No, sir. I would go for ultrasound first, and later on I'll go for tumor marker, sir.
So ultrasound. Anand,
Yes, sir.
yours
Sir,
ultrasound? Yes, ultrasound, please.
for the
Sorry, sir, you are not audible, sir. Your voice is breaking, sir.
Ultrasound.
Sir, ultrasound abdomen showed, sir, moderate dilation of intrahepatic biliary radicals, sir. Along with that confluence was they are visualized up to the confluence, not after that, sir. And gallbladder was not separately visualized, but echoes were there in the GB fossa region, so they gave his possibility of chronic cholecystitis, sir. Also, there is no evidence of free fluid in the abdomen, sir. So no ascites is there, sir. So it gave us the level of block, tentative level of block is at the hilum, sir, and it gave the features suggestive of chronic cholecystitis, sir, chronic calculus cholecystitis, and there is no evidence of ascites, sir.
So did it change your diagnosis? No.
Sir, it changed my diagnosis, and it narrowed it down towards either gallbladder neck malignancy that is involving the hilum, or hilar cholangiocarcinoma, sir.
Yeah. So can that exclude other benign pathology? Which benign pathology can mimic hilar cholangiocarcinoma or GB neck mass?
Sir, patient, though it is a rare diagnosis, IgG for sclerosing cholangiopathy can mimic
Correct, but more common than that, xanthogranulomatous.
xanthogranulopathy.
Okay, it's a very, very strong mimicker of this. And it is in publication, not that I'm thinking. So it's a thing from SGPGA, the publication is there. So now we have narrowed down to these two things. What should we do now?
Sir, we would go for imaging
So
investigation.
is it resectable on ultrasound? On ultrasound, can we say that it is resectable?
Sir, on ultrasound, if we are finding frank evidence of metastasis, then we would say it is frankly metastatic.
That's why it is called a screening test. One is we have an idea about what is the problem, and also we can exclude the metastasis. Second, can we say about the resectability of the disease from here? Can you assess the resectability by ultrasound?
Yes, sir, I won't be able to assess resectability on the basis of ultrasound.
You will be able to assess the resectability, but the sensitivity and specificity or with the accuracy will not be so high. They can tell you about the vessels.
Yes.
Suppose a big mass involving the common hepatic artery, the portal vein, can't the ultrasound show that? And if they apply contrast to that, the contrast enhance ultrasound, the sensitivity and specificity will be much more better. They can give you a fair idea to me. And if he says that there's a big tumor involving the common hepatic artery, the proper hepatic artery, the main portal vein, and even going up to the common hepatic artery area, maybe extending towards the celiac, they can very easily say that. So I'll have a fair say the knowledge about it, that this is possibly a very locally advanced thing which is happening. So they can there, but the answer is the specificity and the sensitivity and the pickup rate or the accuracy will be less. How much less we will discuss later. And then with this, what should you go for?
Sir, I would either go for triple phase CT abdomen with the thorax, sir, abdomen, pelvis, and thorax, sir. Or I can go for MRI abdomen, MRCP along with the CT thorax, sir.
No, you can go for what? But what should the patient is in front of you?
Yes, sir. Sir, I have MR abdomen along with the CT, sir.
Why did you do both? When you can go for both, why you? It's a huge economic burden on the patient, isn't it?
Yes, sir. First, for local staging, we got MRI abdomen with the MRCP, sir. And for metastatic workup, we did CT thorax, sir.
No, you did it, it's fine. My question is, can you manage this patient with CT scan or not?
Sir, we can manage with the TPCT abdomen pelvis with the thorax, sir. But biliary, considering hilar cholangiocarcinoma, MRCP will give us better idea about the local extent of biliary radical, sir.
Then go for MR, not MRCP, MRI and MRCP. So go for MRI. Why are you going for CT scan?
Yes, sir. MRI abdomen with MRCP can be done. That will give us that has got equivalent.
Not can be done. Why you are going for both? Why can't you manage with MRI only? If you are saying that that is better in all aspects.
Yes, sir. We can manage with MRI abdomen alone, sir.
So yes, I would agree by doing a contrast enhance with the MRI, CE, MRI, and MRCP, I can manage this case. That's fine. So what about CT? Is there no role of CT at all?
Sir, CT is better to rule out distant metastasis, sir. So also, in case we are doing MRI abdomen, then also we need to rule out lung metastasis, and then we need a CT along with that, sir.
Can I manage with CT again? So what exactly here in these two conditions, we have CAGB neck versus hilar cholangio. What part the CT can actually show better, and what part actually the MRI can show better?
The biliary extent will be better seen with MRI, sir. But lymph nodal and distant metastatic staging would be better with CT, sir. Vascular assessment we can equally do with both the scans, sir. MRI as well as CT, sir.
So the answer is the delineation of the mass, the vessels, the lymph nodal status are more or less same. So in CT and MRI, in MRI, the ductal involvement is better seen because you see in hilar cholangio, we need to know how far the thickening or the mass has extended along the duct. That delineation is much better with MRI, the biliary one. But you must know, suppose this patient has cholangitis, this patient has a stent, or this patient has cholangial abscess or something, then in those cases, MRI may not be so helpful. And of course, MRI is costly, and MRI has its own problems, the acceptability of the patient. So you are correct, but you should be able to give some answer regarding these two investigations. This is a very common question in all type of abdominal malignancy. You will be asked the difference between the CT versus MRI, and you must be able to say the accuracy rate. It touches about 90% in MRI, and it nearly little bit less in CT scan. But if asked, you can say yes, I can still manage this patient with a multiphasic CT scan. This patient, and the MRCP has the advantage with MRI, which is not there with the CT scan. Okay, so 90% accuracy. And ultrasound, what is the accuracy? It's about 60 to 70%. 60%. So you have done
Yes,
the
sir.
CT scan, you have done the MRI. So
Uh,
what are the significant findings from them?
Sir, shall I share the MRI screen, sir?
Yes.
I'll stop sharing this.
And so share and show us the important findings.
So this was MRI done for this patient, sir. This is a T2 weighted axial scan of the MR, sir. Sir, in this we are able to see gross bilobar intrahepatic biliary radical dilatation with the
Show me the ducts
yes, sir.
starting from the periphery and converge towards the center.
This is segment 5 duct, sir, and this one is segment 8 duct, which are converging there. This is right posterior ductal system, sir. So this one is caudate duct, sir. One of the caudate ducts, sir.
Your cursor is not moving.
Yes, sir. This one.
Caudate. You shouldn't jump to the caudate duct immediately.
Okay,
Identify segment 2, 3, and the right anterior, right posterior sectoral ducts. Then show them how they are converging and reaching the hilum.
Yes, sir. So this one is left ductal system, sir. This one, and this one is segment 4 duct, sir. This one. So these are converging to the hilum, but not forming the hilum, sir. Yes, sir. And this is the mass lesion. This is extending on both the sides, sir. It is extending up till here, sir, and on the right side, sir.
Yes.
And this one is the gallbladder, which is contracted, sir, with the calculi within. And
cursor is not moving.
This one
show
is
me the gallbladder. Show me the gallbladder.
I'm moving the cursor, sir. Is it visible?
So
this one is the gallbladder, sir, and this is the neck region, which is also involved by the tumor, sir. And this one is the right portal vein, sir. This is portal bifurcation, sir. This is right portal vein, sir.
Yes, yes.
And distal CBD again we are able to visualize, which is normal, sir, up till the hilum, sir, up till the ampulla, sir. And
artery,
sir, in the artery. So this is the arterial phase image, sir, which shows this is the right arterial system, sir, and this one is the left one. It is going there.
Yes, sir. Yes.
So this is the portal phase, sir. So this is showing abutment of the main portal vein here, sir, around here, sir. And right hepatic artery was also coursing.
Where is the abutment? I can see a distinct plane between the two.
Sir, and this region, sir, there is abutment, sir, in this region.
Okay, then.
And right hepatic artery is coursing in this region itself, sir.
So hepatic artery is involved or not involved?
Contrast opacification was maintained as we have seen in the arterial phase, but it is abutting the tumor, sir. Okay, so
in the end, what is the diagnosis? And there are no liver SOLs, free fluids.
There are no liver SOL.
I can't find any significant lymph nodes. So what is the impression?
Sir, it is also reaching up to the junction of segment 4 and 2, 3, sir. here. This is segment 4 duct, which is joining here to the 2-3 duct, sir. And this part, whole of the part is mass lesion, sir. This whole of the thing is mass lesion, sir. So, though it is involving.
What is the extent of disease now?
Sir, it is bismuth correlate type 4 disease, sir. It is involving the confluence of right anterior and right posterior, and it is involving the segment 4 and 2-3 ductal confluence, sir. So this is type 4, sir.
Type 4 what?
Type 4 bismuth correlate cholangiocarcinoma, sir.
So could it be still GB neck mass?
Yes, sir. It is involving the cystic duct origin, sir. And we are not able to visualize neck separately. So it could still be GB neck mass, sir.
But if you are to say one thing, I would say it is because GB neck mass going to the left side is very, very uncommon. So I would say that it is a possibly a hilar cholangio. It's a hilar cholangio or it's a perihilar cholangio?
Sir, it is a perihilar cholangio, sir.
It's a perihilar cholangio. What is the difference between the two?
Sir, hilar cholangio would be involving the hilum itself. Perihilar cholangio would extend up to the secondary biliary radicals on the both sides and above the origin of the cystic duct, sir.
The hilar has two parts, one extrahepatic part and intrahepatic part. Okay. And so what we are most probably here witnessing is the extrahepatic part of that. So the perihilar, it's better to say it's a perihilar cholangio, and it's a you are saying bismuth type 4, but I'm not sure whether you know or not the recent AJCC classification. They have excluded the bismuth type 4. That is the change which was there earlier on. It's not there now. They've excluded type 4 because they don't find any difference to type 3 and the type 4. Okay. So now what to do? What feature here would make this disease unresectable?
But it is involving both the secondary origin of the secondary biliary radical, sir. On the left side, it is involving the junction of confluence of
one is involvement of unilateral secondary or bilateral secondary?
Bilateral secondary, sir.
So bilateral secondary radicals involvement is a contraindication. Second,
sir, it is showing. Though it is showing,
second, what would make it unresectable? Second point, any vascular?
Sir, and involvement of right hepatic artery and involving the left confluence. So it is contralateral involvement that will make it
contralateral involvement. Third,
involvement of main
proximal hepatic proper hepatic artery and main portal vein. So if they are there, so some people say that in case of hilar cholangio, even proper hepatic artery and main portal vein could still you can reconstruct and divide. That is a matter of debate, and you have to say you have to quote the literature to establish that. So at this stage, you can say that if these are there and not go for surgery. So this is a resectable hilar cholangiocarcinoma, possibly type 4 or type 3A or type 3B. What?
Sir, it is more towards the right side, so I would say type 3A, sir.
So if you are not very sure about whether it is a type 3A or type 3B, so and you have to do a hepatectomy, which hepatectomy you should do?
Sir, I would do right hepatectomy.
Right one. So right one, you will be more correct. So that's what is described. So go for right one, which is actually histologically more involved in these patients. Okay. Now, what is the treatment?
Sir,
would you do a tumor marker?
Sir, I would do tumor marker, but it would be elevated in the jaundice patients, sir, undrained system, sir. But still, I would do tumor marker because in some patients it can be still normal.
So the answer is correct. I would rather like to get a tumor marker done after reducing the jaundice. So if it is not that, maybe I would have a baseline tumor marker. Which tumor marker? But they would not really diagnose the patient. It's more of a follow-up type. And if they are more than 1200 or 1000, maybe I would hunt for metastasis in these people. Okay, that is the answer. And which tumor marker?
Carbohydrate antigen 19-9, sir. We will do.
Only? No, you have to say even CA99 and CEA
also.
both. And CEA both. So I will get both of them done. And then I will plan for what?
Sir, I will plan for drainage of the functional liver remnant, sir, which we are tentatively planning to preserve, sir. And then we will look
plan.
for.
That means you have planned for surgery.
Sir, for this patient, we could consider.
Take it as a type 3A. Okay.
Yes, sir.
You are taking a type 3A or type 3B?
Sir, type 3A, sir.
So suppose it is type 3A. I am in confusion. Can I confirm this?
Sir, I would go for endoscopic ultrasound to confirm this extent, sir.
Yes, endoscopic ultrasound is more specific, sensitive, and accurate, and also it can show the lymph nodes, and also you can take FNAC from this if it is required. That is there. But will endoscopy ultrasound be able to show exactly the ductal involvement in the hepatic intrahepatic part?
Sir,
what else can show the exact ductal, more specific in showing intraductal involvement?
Sir, cholangiogram can give us the better picture in such areas.
No, cholangiogram, you see, before, of course, you can say role of ERC if you are asked. ERC, endoscopic retrograde cholangiogram can show you the ductal involvement, yes. And it can take a broad cytology, which is very specific in diagnosing. But exactly you can't go to second order biliary ductules in endoscopic retrograde cholangiography, isn't it? You can show up to first order. You can't go into the second order. So suppose the second order is involved or something. What is that thing?
Percutaneous transhepatic cholangiography I would do, sir.
Yes, cholangioscopy or not graphy, cholangioscopy. You can see the ductal involvement. Some people do it. It's not absolutely necessary to do that. So in this patient, we say that it is type 3A resectable cholangiocarcinoma, hilar cholangiocarcinoma. So what is the treatment of choice?
Sir, I would first drain the functional liver remnant and look for functional liver volume, remnant liver volume, and
treatment of choice is surgery.
Treatment of choice is surgery, yes, sir.
Treatment of choice is surgery. And then
it's 10:30, so we have to.
Okay, so treatment of choice is surgery. Okay, we will stop here at some other time. Maybe we will. Then I'm just saying
management of
let me tell you 3 or 4 lines about this. So the treatment of choice, the best treatment for these people is surgery. Now surgery includes the ductal resection, the associated part of the liver has to be removed in these patients, and before that we have to reduce the jaundice to less than 3. All these are evidence based. So less than 3, that come down, the enzymes should come down to acceptable level, maybe below 100 enzymes. You don't wait for the enzyme to come down to normal, but we want the bilirubin to come down to normal. And for that, if you are asked, maybe I'm not sure whether you know it or not, the literature has established that the better than PTBD, the endoscopic nasobiliary drainage is better in this patient. for drainage of for reduction of the jaundice. So I'll do a ENBD, and then I will plan the patient for surgery. And the surgery have many options depending upon the involvement, starting from standard resection. The standard resection is left or right hepatectomy with lymph nodal clearance and resection of the caudate lobe, because the caudate lobe ducts, they drain into the hilum. Okay, then there are extended resections. Extended resection is where the duct, you don't get a ductal margin negative towards the pancreas. So the extended resection involves the standard resection plus pancreaticoduodenectomy. That is hepatopancreaticoduodenectomy. Okay, or it is a standard resection plus vascular resection. Then it is called extended resection. Extended resection is standard plus pancreaticoduodenectomy or standard plus vascular resection. And if you do hepatopancreaticoduodenectomy and vascular resection both, it is called super extended resection. Okay, and if both the sides are involved, you're not able to go for surgery or it's a locally advanced one. There the debate start whether I should go for a neoadjuvant therapy in this patient or chemotherapy in these patients, or I would go for liver transplant. And more now people are opting for liver transplant in these patients, provided the patient meets the Mayo criteria. You know what is Mayo criteria?
Yes,
So the Mayo criteria is the tumor has to be solitary, less than 3 centimeter, no lymph node, and but unresectable. In this patient, you can go for liver transplant. Otherwise, you have to you go for chemotherapy. Now, after surgery, obviously, if node is positive or margin is positive, then you plan for adjuvant therapy in terms of chemotherapy. What chemotherapy? Usually, that has been used in trials is the gemcitabine and oxaliplatin. Okay, but recently the trials have shown that in place of gemcitabine, which drug has shown to be more effective?
The capecitabine-based protocols are coming.
No, recent trials have shown that in place of capecitabine, if you use fluoropyrimidines, that gives better result. So better result in terms of survival. So you should be able to know one or two of the trials, particularly the BILCAP trial. Okay, and the SPAC trial, the BILCAP trial, at least 2, 3 you must be able to know. And finally, you should be able to answer what is the survival in these patients.
5-year survival in this patient after R0 resection is up to 50%, sir. With extended resections also 30% 5-year survival.
Stage wise. If stage 1, if you do not treat a hilar cholangio, what should be the lifespan? It is better than CAGB. In CAGB, in cancer gallbladder, it's more aggressive. This is less aggressive. If you say that the median survival is 3 to 6 months, here you say about 1 to 2 years, provided you take care of the jaundice and the symptoms. So stage 1, you can happily say that a 5-year survival is at least 60%, and that gradually and slowly drops down to 30% in different series if you do a curative resection and give adjuvant therapy in case of hilar cholangio. Okay, so that's all. Thank you. You presented well. So little bit fine tuning is required. Okay, Anand.
Okay, sir. Yes, sir. Thank you, sir.
Thank you very much.
Yes, sir. Thank you, sir.
Thank you.
We are closing the session. Thank you.